Direct Support Professional Annual Training. Module 5, Supporting People with Dual Diagnosis.
Hello everyone, I'm Dr. Gentili, Chair of the Department of Psychiatry at Wright State University. I'm the Project Director for Ohio's Coordinating Center of Excellence in Mental Illness, Intellectual Disability, and Ohio's Telepsychiatry Project for ID. I work with DoD as a consultant, and as part of that work, I am honored to present this training on supporting people with dual diagnosis. By way of introduction, mental illness and developmental disability are two different conditions, but people with developmental disabilities are more likely to have mental illness. Mental illnesses can affect memory, perception, judgment, and a person's ability to understand or comprehend what is going on around them. The term dual diagnosis is used for children and adults who have a developmental disability along with a co-occurring mental illness. Mental illness is treatable. People with developmental disabilities, however, do not often report their own symptoms. As a direct support professional, you have the opportunity to monitor and document information that may be valuable to a mental health professional. This can be a big responsibility, but you can help identify mental health problems, possible side effects of medications, and substantially improve the lives of the people that you support. Next, let's talk about communication. People with dual diagnosis may have different communication styles that you will have to adapt to, especially when having conversations about symptoms of their mental illness or side effects from medications. Here are some strategies that you can use to communicate with more effectively and better support them. Try not to use too many yes or no, multiple choice, or either or questions. Some people with ID may answer these questions the same way over and over, or choose the last choice due to memory problems. Consider using cross-questioning. This strategy helps to check the accuracy of answers. An example is, do you sleep well at night? And this could be later followed up with, do you have trouble sleeping? Avoid double-barreled questions. A double-barreled question is when two questions are combined into one. An example of a double-barreled question is, do you like your home and the DSPs who support you? A better way to communicate would be to split this up into two separate questions. Avoid asking long and multiple questions, such as, do you or do you not like your job? And if so, what is the most and least favorite thing about it? Avoid leading questions, such as, you knew you weren't supposed to do that, didn't you? When spending time with the person you support, pay close attention to their mood changes, attention span, and unusual or repetitive behavior. This knowledge of their nonverbal communication can provide mental health professionals with valuable information. Asking what else, if the person gives you partial information, may give them more opportunities to provide additional details. Use directed, open-ended questions, such as, when you went to the movie theater and looked in your wallet, what was missing? This helps to take the person back to a specific time and place, but remains an open-ended question so they can share information freely. Summarizing and recapping what you think the person you support has communicated with them can be a useful strategy to ensure that you did understand correctly. Remember, these are just suggestions. You know how the people you support communicate best. It's not necessary to use every strategy, and not every strategy will work for each person. Next, let's talk about baseline functioning. Mental health professionals may ask DSPs to help document someone's baseline functioning. Using this documentation that you provide, mental health professionals can establish a normal or baseline functioning for each person that you support. Some requests for information or documentation may include describing what type of communication style the person prefers when interacting with doctors or other healthcare professionals, or identifying details of when the person was last doing well, such as what medications the person was taking and when, environmental factors, support system, and quality of life factors. Next, let's talk about transition age. Transition age, which is usually considered between ages 14 and 26 years, brings with it many major life changes. People are transitioning from school settings to work settings, and often from family homes to other types of supported residential settings, among many other changes. This is a difficult time for everyone, including people with developmental disabilities. It's also common for mental health issues to present themselves for the first time or other mental health conditions to worsen due to the multiple changes during this time. Next, we're going to talk about grief versus depression. Grief and depression are not the same. The first stages of grief after an event, such as losing a loved one, usually last less than 2 months, and suicidal thoughts are not present in normal grief. The person may have feelings of loss, crying episodes, short periods of psychotic symptoms, but then return to baseline. In depression, the time course is greater than 2 months, suicidal ideation is more likely to be present, and the person's emotional state may include feelings of worthlessness and blaming oneself. Psychotic symptoms may be long-lasting. Mental health professionals may recommend treatment for depression that can include medications and/or counseling. The medications may take 1 to 2 months for an adequate trial at each dose. Next, we're going to talk about psychosis. Psychosis includes delusions, which are fixed or false beliefs. These may be paranoid, grandiose, religious, or disorganized thought processes. Hallucinations may include hearing voices, seeing things that are not there, smelling odors that do not exist, feeling things on one's skin, or unusual tastes. If a person you're supporting is paranoid or has other delusions, realize that it is true for them. Do not confront them and do not agree or argue with them. Focus on the person's emotions and engage the person with their needs in the moment. For example, you could say, "It sounds very scary. How can I help you?" Psychosis is more common in the general population, but despite the lower prevalence in people with dual diagnosis, antipsychotic medications are still commonly prescribed as a treatment option. Because of this, you should consider the prescribed antipsychotic medication side effects as a possible cause of the psychosis and document any medications taken, dosages, and times. Hallucinations may look like the person is talking to themselves, staring or appearing preoccupied, repeatedly brushing unseen material off their body, grimacing or wincing as if they're smelling or tasting something foul, shadowboxing, or striking out for no apparent reason. Delusions may manifest when a person thinking a TV or movie hero is real and part of one's life, thinking that people are talking about them or trying to hurt them, stating or behaving as if food is poison, inspecting or refusing food in a manner that suggests fear, glaring with intense angry facial expressions at strangers or with people they had previously liked. Next, we're going to talk about psychiatric medications. Polypharmacy is a term used to describe when someone is taking too many medications. The doctor prescribing the medications should be screening for the following conditions that can be associated with polypharmacy. But if you notice them, it's important to report them to the healthcare professional. For example, some things to report include weight gain, increased blood sugar, cholesterol, movement disorders including shaking and tremors in the hand, head, and neck areas, uncontrolled, stiff, jerky movements of the face and body. Things to consider include, if there's a therapist involved, DSPs may be asked to keep regular contact with the therapist by sharing problems or concerns that occur between sessions. This communication can be key due to the fact that people with developmental disabilities may not recall past actions. A person familiar with the person and their symptoms, behaviors, and history should attend psychiatric appointments to give necessary background information. Treating psychiatrists will need accurate information about any recent changes in the person's medical condition and a description of current symptoms and mental health status. This includes the current status of sleep, appetite, mood, changes in behavior. Without this information, it will be very difficult to make changes to that person's medication regimen. Making sure to support the person's mental health treatment is essential. Outcomes for mental health treatments improve with frequent and consistent attendance in therapy sessions and psychiatric appointments. Next, we're going to talk about psychological first aid key points. As a DSP, supporting the person to live as healthy as possible, both physically and mentally, is a vital part of your job. Just as there are first aid for physical health problems, there are many things that you can do in your supporting role to provide psychological first aid. Model healthy responses. Be calm, courteous, organized, and helpful. Be visible and available. Maintain confidentiality as appropriate. Remain within the scope of your expertise and your designated role. Be knowledgeable and sensitive to issues of culture and diversity. Pay attention to your own emotional and physical reactions and practice self-care. Ask simple and respectful questions to determine how you may help. Speak calmly. Be patient, responsive, and sensitive. Speak slowly in simple, concrete terms. Don't use acronyms or random terms or jargon. When communicating through a translator or interpreter, look at and talk to the person you are addressing instead of the translator or the interpreter. Remember, the goal of psychological first aid is to reduce distress, assist with current needs, and promote adaptive functioning, not to elicit details of traumatic experiences and losses. When working with trauma survivors with disabilities, keep in mind, if communication, hearing, memory, speech seems impaired, speak simply and slowly. Take the word of the person who claims to have a disability, even if the disability is not obvious or familiar to you. When you're unsure of how to help, ask, "What can I do to help?" and trust what the person tells you. When possible, engage the person to be self-sufficient. Here are some behaviors to avoid. Do not assume that everyone exposed to a disaster will be traumatized. Do not treat people as if they are broken or abnormal. Most acute reactions are understandable and expected, given what people exposed to a disaster have experienced. Do not talk down to the survivor or focus on their helplessness, weaknesses, mistakes, or disability. Focus instead on what the person has done that is effective or may have contributed to helping others in need. Do not assume that all survivors of trauma want to talk about it or need to talk to you. Often, being physically present in a supportive and calm way helps affected people feel safer and more able to cope. When needed, try to assist in an area with little noise or other stimulation. Address the person directly rather than the caretaker unless direct communication is difficult. When should you seek mental health treatment for someone? Mental health treatment can and does improve the quality of life of people that you support. Untreated mental illness can impact the level of care a person needs and can lead to more restrictive settings, as well as limiting educational and employment opportunities and abandonment by family. Recovery from mental illness is possible. Some common myths include people with developmental disabilities do not have significant mental health concerns. Another myth is people with developmental disabilities cannot participate in or benefit from counseling. Another myth, people with developmental disabilities are already being provided therapeutic services, so mental health services are not necessary. Mental health treatment helps stabilize symptoms of mental illness and improves a person's ability to express their feelings and emotions. It improves interpersonal relationships and the coping skills needed to handle life stressors and deal with mental health symptoms. Mental health treatment also improves a person's self-image and self-esteem. It's critical to remember that all behavior is purposeful and a form of communication. Aggression and other behavior changes are common occurrences in people with developmental disabilities. These behaviors may look like self-injurious behavior, verbal aggression, property destruction, physical aggression, or sexual aggression. Mental health professionals should consider underlying health conditions that might be causing a person's aggression. Aggression is more common in people who live in more restrictive environments, have mental or physical instability, and who have reduced involvement with their family. Also, DSPs and other caregivers have an increased risk of stress, burnout, and potential injuries. Everyone deserves to feel safe and protected. When to be concerned. When a person experiences a significant life stressor, for example, the death of a loved one or a move to a new environment, which has triggered the onset of mental health symptoms, including sadness, crying spells, insomnia, excessive worrying, irritability, skin picking, anger, or aggressive behavior. When a person makes threats or actual attempts to harm themselves or others. When a person is unable to care for their basic needs. When a person loses touch with reality, for example, a person experiences auditory or visual hallucinations or delusional thinking that leaves them unable to make even simple decisions for safety. This may look like refusal to eat or hearing voices. When a person receives psychiatric services through a mental health program and there are questions or concerns regarding medication side effects. If you notice any of these signs or expressions, contact the person's mental health professional or request a referral if they did not already have services from one. What works? Interventions besides medications can be very helpful, including counseling, positive behavior supports, trauma-informed approaches, and services outside the DD system, such as environmental and sensory interventions, among many others. Communication amongst team members is also critically important. Ensure that everyone is working together to achieve the same goal for the individual. Acknowledge positive behavior and the use of coping skills and strategies. Put yourself in another person's place and think about the control that others have in their lives. This often includes who they will live with, where they were, what they eat, and the clothes they wear, etc. People with developmental disabilities often are not given choices regarding things like caffeine, coffee, soda, cigarettes, etc. While people should still be encouraged to take care of themselves and make healthy choices, mandates for eliminating all of the person's choices and options will instill an environment of control, and it will result in rights violations and the need for approval of restrictive measures. Next, we're going to talk about suicide and developmental disabilities. A person with developmental disabilities may have other factors that make them more likely to complete suicide, including their disability status, mental health diagnosis, a history of trauma, recent stressful life events, chronic pain, or impulsivity and agitation. Anyone who shows signs that they are thinking about suicide should be taken seriously, and DSPs should follow the appropriate steps outlined in the person's mental health treatment plan or their individual service plan, or ISP. DSPs can also call 911 or local or national crisis numbers. These behaviors may be signs that someone is thinking about suicide, talking about feeling empty, hopeless, or having no reason to live, making a plan or looking for a way to kill themselves, such as searching for lethal methods online, stockpiling medications, or buying a gun. Talking about feeling trapped or feeling that there are no solutions. Using alcohol or drugs more often. Withdrawing from family and friends. A change in eating or sleeping habits. Showing rage or talking about seeking revenge. Or talking or thinking about death often. Next, we're going to talk about anxiety disorders. Anxiety disorders are the most common mental disorders. Anxiety is treatable, and if it is suspected, the person should be evaluated by a family practice physician or a psychiatrist, depending on the severity. To determine if a person should consider seeking treatment for their anxiety, ask these questions. Does it disrupt the daily schedule or plans? Is it causing the person to be late? Is it interfering with relationships? Are these symptoms taking up more than 1 hour daily? Are the symptoms causing other mental health symptoms? Is the individual struggling? Perseveration, which is repeating comments or questions over and over, is usually related to anxiety and can be addressed by a mental health professional providing guidelines and boundaries to reassure the person. With support from the person's team, DSPs should reward or acknowledge when a person follows guidelines or boundaries outlined by a mental health professional. Post-traumatic stress disorder, or PTSD, may occur when a person has experienced trauma. Trauma is common with people who have experienced sexual, physical, or emotional abuse. Exposure to life-threatening events typically invokes a fear response, helplessness, and panic. People may exhibit the following: re-experiencing. This is thinking about the trauma over and over. Avoidance, refusal to participate in activities or to talk to people. And third, arousal, increased emotional or motor activity in response to the situation or environment. A DSP identifying and recognizing the signs of PTSD can be the first step to getting the person the right supports and the right treatment. Here are some practical suggestions. Avoid overcrowding situations during mental health appointments. Try to reduce loud and irritating noises, intimidating direct eye contact, unnecessary invasion of personal space, direct confrontational stances, and anything that may appear intimidating. Don't underestimate effective planning. Use a calm, soothing tone of voice. Express concern for the person's well-being, offer food or drink, allow a phone call to a trusted support person, try to decrease wait times, redirect the person with more positive activity, remove potentially dangerous items from the area, and redirect verbally as appropriate. Practice de-escalation strategies and work as a team. Talk about it after the fact to determine what went well and what are opportunities for improvement. That concludes this training on supporting people with dual diagnosis. I'm Dr. Gentili. Thank you for joining me and for all of the important work you do in supporting individuals with dual diagnosis.